privileges are accumulating for one group and disadvantages are accumulating for the other group.
It wasn't until I started studying medicine that I really saw where the problem came from. It starts within the curriculum, and I think this is where the curriculum should be cured.
When you become a lot more representative and inclusive as a healthcare workforce, you will be able theoretically to achieve excellent healthcare. Because right now,
welcome back to Curing the Curriculum. Today we're tackling something you probably have noticed but might not have the language for yet. Look around the lecture hall and then look at the patients in the waiting room. Do you see a difference? At least in the Netherlands, the difference is striking. Here, 74% of the population has no migration background, but it's 85% when we look at registered healthcare professionals. So, somewhere along the way, we're losing people, and it's not by coincidence. This phenomenon has a name, the leaky pipeline. And today we're joined by two people who aren't just researching it, they're actively trying to fix it. Soumeya Mezian and Lianne Mulder, welcome.
Thank you.
Could you maybe introduce each other and tell the listener what they should know about the other person?
So Lianne is the most amazing researcher in all of the Netherlands. She recently defended her PhD thesis in May. She researched where along the way the leaky pipeline has the leaks and what causes the leaks, and also what type of people benefit the most from the leaky pipeline and what people are the most affected by it, what type of people, what demographic groups, what demographic characteristics influence your chances of getting admitted into a medical specialty or even into med school in general, or in the first place, and also every other healthcare profession that requires selection in the study. What else should I say about Lianne? She is an educator, and she's truly a pioneer in this world and the way that she fights for justice. And I don't know if this is too much. Yeah, I think I'll keep it at this. And she's also Dr. Mulder, of course.
That's too sweet. Oh my God. Too much honor.
According to my grandma, you're a professor, so it's like we're keeping it mild now.
Her grandmother is a really amazing cook, by the way. I had the honor to have dinner at her family's house, so it was very delicious Moroccan food. Amazing. So Soumeya is a really amazing student. I met her when she was a bachelor student of medicine, and she was really inspiring to me in terms of how she wants to, for example, help other people to also advance in the medical world, be an example to young people who might want to study medicine or another healthcare study. She is helping to make healthcare more accessible by working as well as a multilingual translator. So she works as a translator. And in the Alzheimer's Center, right?
Yes.
So when there are elderly people who might have Alzheimer's who speak the languages that she speaks, then she will assist them. And she was nominated for the Echo Award. Unfortunately, she didn't win. I really think she should have won because she's doing so many great things. And she wrote her bachelor thesis under my supervision about the importance of diversity in the gynecology workforce and the benefits that diversity has in this field for patient outcomes, for example.
Wonderful. Soumeya, you're quite young.
Yes.
So what decided you to take on this huge topic of healthcare inequity?
So I am quite young. I'm 22 years old, but my entire life I have always not just been Dutch, as I was born and raised here, and it was my first language, but I also speak other languages. And with that comes culture, and with that comes a background of seeing my loved ones having to look for care and not having the same access as their peers who don't have a migration background. I'm Moroccan, and in Morocco, I'm also from a marginalized group. I'm from the Rif Mountains. We speak Tarifis, or the Rifian Amazigh dialect, which is also a dying language, and it's a region that has faced a lot of struggles. And then oftentimes people come to Europe looking for a better life and better chances. And then in the Netherlands, they're still a marginalized group. I come from a very privileged place in that my parents both speak Dutch. They both went to school here. My mom was born 2 kilometers away from where I was born in Rotterdam. My father came here very young, and he also enjoyed an education here and upbringing in every way. So, and I should also mention that everyone in my family is also sort of in the medical field or either in the healthcare profession. And still they were coming across a lot of struggles in terms of being listened to, in terms of taking their cultural context into consideration when getting to a diagnosis. So it was also always something that I was aware of. It wasn't until I started studying medicine that I really saw where the problem came from. I was sitting in the lecture hall, and I was like one of 10 students who did have a migration background. Obviously, those weren't every student in our year, but it's something that you notice, especially being from Rotterdam. It's a very diverse city. We see everyone and everything that has ever walked the earth, but still it was very confronting that in these circles there weren't a lot of people who looked like me. And we often had patient lectures. So patients would come and visit, and we would discuss with an internal medicine specialist or someone else something that was just relevant to the topic or the subject that we were learning about at the moment. And I remember that we had a guest lecture from an internal medicine specialist, and he brought a patient with him. And when the patient walked in, I immediately saw that he was a Moroccan man. It was like very obvious to me. And this physician, he always had a sort of like, he had this thing where he would always start his patient lectures with something about where the patient was from. So we had patients that were from Schiedam, and then he would have the windmill from Schiedam in there as the first slide. And we also had like certain patients that were from Zaandam or the other areas. And for this patient, he put in the pyramids. I was like, okay, we don't really have pyramids in Morocco, you know? So I sort of glanced over it, and I was like, okay, maybe just I assessed him wrong. He's not actually Moroccan, he's just Egyptian. I assumed that the doctor would know since he was his physician. But one of the students who was actually Egyptian, he came to the patient. He was like, oh my God, are you Egyptian as well? And he was like, no, I'm not. Why would you assume that? I was like, well, the pyramids are on the first slide, and he always does this thing about where the patients are from. And he said, no, I'm actually Moroccan. So it was right around the World Cup of 2022. And he took out the picture of the pyramids and he added the Moroccan football team. And when they started talking, they always start with the symptoms, and then we can ask questions. Obviously, they already know what the diagnosis was or what was wrong, but we have to get to it ourselves, with air quotes. And this man had a lot of problems. He had muscle spasms and eyesight problems, and there was a lot going on. And it's like they did every test in the book, except for the first thing that I would think of whenever I see a Moroccan person, even without a medical background, when we were young, and certain friends would say, well, I'm so tired all of the time. I would just say, well, I think you should maybe supplement your vitamin D, as we are from Moroccan background, but we live in the Netherlands. And with this man, his vitamin D levels were just never tested. And that was so weird to me, because it's something that I immediately thought of as maybe being a problem and maybe causing a problem. And in this case, he had a severe vitamin D deficiency, which led to all of his problems and the muscle spasms and everything. And I really just couldn't wrap my head around how nobody thought to test the vitamin D levels of a Moroccan man living in the Netherlands. And I thought, okay, well, apparently they just don't know us, and they don't know how that is a problem for us. That was the first thing. But then we started talking about different subjects. And I would really notice that a lot of people just never really met people who didn't look like them. And once again, being from Rotterdam, that was something that I could never have imagined, because you would meet people who don't look like you would talk with people who don't look like you would live with them, you would visit them, and it was very normal. It's like the most normal thing with us in Rotterdam. You know everything about everyone, and you learn a lot about the world. But in the lecture hall, I noticed that a lot of people really just only lived in their bubble and never learned to look outside of it. And that was like sort of my first awakening. And then I started at the outpatient clinic in the Alzheimer's Center. And there were all of these amazing researchers that I'm so grateful to learn from, who really had the expertise in where things were going wrong within the system. And then you start to notice things. And you start to think about it, and you start to talk with people about it. And I met this amazing friend of mine who's also a sociologist, and she introduced me to Lianne. And everything from there is just history, because once I was involved, I couldn't get enough of it. And I always want to get to the root of this problem and how we can actually make it better for the patients, for all our patients.
Yeah, I think once you see it, you can't unsee it.
Yes,
and
definitely.
You now have also the scientific side on top of your experience side. So thank you for everything you're doing. And indeed, it is very fun to think about such a undiverse lecture hall in such a diverse city. Quite the contrast. Lianne, you realized probably at some point that diversity maybe is not just a nice to have, because you decided to dedicate your entire PhD to this topic and to research it very thoroughly. How did that come?
Actually, it's there's a little bit of a background story, I think, to it. I did my bachelor's in international development studies. And towards the end of my bachelor's, I already felt like, maybe what we have learned is quite Eurocentric, which is weird when you're studying international development. So why is it that most of the authors that you read are like white Western people when you have a student population who mostly wants to work internationally? And the university had lots of PhD researchers from African countries, from Latin American countries, from Asian countries, from Arab countries. But we never had them as teachers. And I always found it so weird. Like, why are they in all these halls of all the departments and they don't get to teach? Why are all our teachers basically white? And sometimes teachers would give examples where I'll be like, yeah, maybe 30 years ago in a specific African country, maybe it is correct what you're saying, but that was 30 years ago. For example, we had a teacher who spoke about people not having landlines. And I had been to Ghana and I'm like, yeah, because everyone has a mobile phone by now. Like, why would they all have landlines when they just jump straight to mobile phones? So I thought that, some of the knowledge that we got wasn't really based on the reality. And then I started with the master's because people had told me like, yeah, the master's is a bit better, it's less Eurocentric. And then it turned out that in my view, it was still quite Eurocentric. And one day we had a class where we had to watch a documentary about some anthropologists who decades ago went to some quote-unquote undiscovered tribe somewhere in the Amazon. Because, of course, if Western people don't know you exist, then you are undiscovered. And they had gone there to study this tribe. And then they had come up with the idea that, hey, we might have all sorts of viruses or diseases that these people cannot handle. So let's vaccinate them. But then they did that with vaccines where apparently there was like a part A and a part B, and they only gave one of them. And as a result, within a few days, all of them were dead. And you saw in the documentary, like they were filming all these like almost naked people laying on the ground in the middle of the Amazon rainforest. And it was like a tribe where, people would wear barely any clothing, right? Just a little something around the waist. And you see just this camera going over all these naked or almost naked bodies, everyone being dead. And it was very, very shocking to me. And then it became more shocking that the professor told us that all the researchers involved in this whole case had never gone to jail. So they were still able to go to conferences where they presented the findings about what they learned from this tribe until they accidentally killed them all. And the professor asked us what we thought. So I said, this is the most racist thing that I've ever seen. And I thought that everybody would view it that way. And then basically a sea of white faces turned to me and was like, not everything is about racism, Lianne. And, people said, like, if you want to fight racism, then why don't you go to South Africa or to the United States? This is Netherlands. Why do you always bring up this? Or slavery, blah, 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 blah. And I was so shocked. And I realized, like, that day I made the decision that I'm wasting my time here. There's nothing I can learn at this place. Because to me, it was so obvious that this was extremely racist. Like the fact that this happened and that there was never any punishment. So I said to some of my classmates, imagine that some African researchers would come to a little village in France and then vaccinate everyone accidentally in the wrong way. And then all of these white people in this French village are dead. Do you really think that the African researchers would be able to live freely for the rest of their lives and present their findings at conferences? No, that is just not how this world works. So that day I decided to quit my master's and I looked for another program. And then I decided to go to Barbados to study sociology there, because I found that on their website that the sociology program was really focused on post-colonial, anti-colonial, decolonial perspectives. And I thought, yeah, that's what I want. That's what I've been missing here. I want to learn about the perspectives, the sociological perspectives and theories from people who have been colonized, whose ancestors were enslaved. I thought that would be so much more useful to learn than the perspectives of a lot of like old white dead men that have not faced a lot of these systems of oppression. To me, it's more educational and more intellectually challenging to learn from perspectives that are new to you and viewpoints that you've never been in as a white person, like standpoints in life. So that's where I went. And like Soumeya said, the rest is history.
Nice, because I think, if you're not affected by it or you never get in touch, you never have this sort of example happen to you, or you don't know about the science, it's very easy. It doesn't really affect you. So why should you care about it? But actually, you have presented quite a lot of data in your different studies. You've also written a report for the Dutch government. There's a lot of data that says what's happening and why we need to change. Could you maybe share with us a little bit about the current situation and what sort of data you've found?
Yes, so I looked at the BIG register. So that is a register in the Netherlands with lots of different healthcare professions, and people who want to practice in those professions need to be registered in that in order to be able to do their job. So, for example, physicians, pharmacists, healthcare psychologists, dentists, nurses, psychotherapists, midwives. Yeah, so there's a bunch of occupations that are in there. And what I did is that I merged that data set with other data sets from Statistics Netherlands microdata to investigate the diversity on a lot of different variables, such as sex, migration background, socioeconomic status. I looked at whether they had parents who were also in the BIG register. So I also looked at their connection sort of to the medical field. And what I found was that lots of healthcare professionals are coming from higher socioeconomic status backgrounds. For example, physicians disproportionately have rich parents, especially high-income fathers. What I found is that people with a migration background are underrepresented in all the fields except dentistry and pharmacy. That women are overrepresented in most fields, and that especially amongst the younger population, women are the vast majority of all these occupations, except in some medical specialties. But there's very few left where men are in the majority, like orthopedics or general surgery, cardiology. And what I also saw is that a lot of people have a parent who is already in the big register, and it's that percentage is also increasing over time. So that shows that access to the medical field is partly based on, your previous social network in the field. So if somebody close to you, like your mother or father, is already a healthcare professional, then it seems that it facilitates your motivation to go and study the same thing. So, of course, partly that's normal, right? Like children of farmers are more likely to become farmers than children who are not children of farmers. But here there's a specific access issue because a lot of these programs use selection in order to determine who is admitted and who is rejected. And that is a part of the pipeline where those influences are unfair. Because if you don't have parents who are medical professionals, that's not your fault. Right? There's nothing you could have done to make sure that your father or your mother was a physician or a dentist. So I looked at, which factors are really of influence in getting into these professions, both in my PhD and in my postdoc research. And then you see that privileges are accumulating for one group and disadvantages are accumulating for the other group. And if you do that over and over again in this whole pipeline from child to becoming a medical professional, then in the end, the medical professionals just don't reflect the society anymore. And that has influences on the healthcare outcomes of patients.
Yeah, maybe you could elaborate a little bit on the last point, because everything you said prior sounds fair, might be an issue. Could also argue against it and say, well, then you know what you're getting yourself into, right, if your parents are doctors. Mm-hmm. But there's a real issue in then the healthcare quality, right?
Yes, definitely. And I think Soumeya knows a lot about it because she wrote her thesis about the subject.
So in this specific instance, research shows that whenever there are two issues that could happen. We looked at two factors. First, there's the ethnic concordance between the patient and the physician. So if you have a doctor who looks like you, it actually improves your health outcomes. It's seen across a lot of specialties. An example that was recently very much getting a lot of attention, and rightfully so, was, for example, Black maternal health in the USA. And our colleague that we are also working on some research with is very specialized in this middle-dop. She's amazing. And she also taught me a lot about this subject. So a lot of Black women would die during childbirth as a consequence of complications. And they researched this phenomenon and actually found that whenever Black women or Black birthing people had a Black physician, their chance of dying during childbirth was significantly lowered. And the health outcomes would improve. So that's the issue of ethnic concordance. And we have also found that across a lot of specialties, this is very relevant. And then we have the second factor, which is very, very important, and that's language and the language concordant care. Because a lot of things go lost in translation. And it's something that's said, but it's something that you really feel within healthcare systems. So whenever a patient and a physician cannot directly communicate with each other, it affects the trust between the patient and the physician. It affects their health outcomes. And it affects the patient care experience, which is also the case for ethnic concordance, by the way. And these are things that you actually see a lot in practice as well. So at the Alzheimer's Center, there are a lot of researchers who went to look at this problem because they noticed that it's a problem, especially in dementia care or dementia diagnosis. In this specific instance, it's that a lot of tests were not accommodated to the patient population. For some point that they started to recognize a pattern was when they had women who came to the outpatient clinic to get diagnostic research for their dementia or even their memory problems. And these were women of Turkish descent, and they got these pictures of igloos. And they were just black and white pictures that didn't have any color or anything that could indicate that it's a cold environment. And these women would point at the pictures and say, well, of course, that's an oven, because that's their reference. According to the like the diagnostic instrument that they were using at that time, that's a wrong answer. And that might be seen as their memory being impaired or they have like issues. But in reality, they are perfectly fine. They just don't have the same reference or the same perspective as, for example, a white patient. And in specifically, for example, Moroccan patients have the same problems. So that's why at the Alzheimer's Centrum, their anniversary was 10 years ago. 10 years ago, they started the memory clinic for immigrants. And we sit at the consults as interpreters. We translate everything that is being said in the room. So from Dutch to, in my case, Tarifit, and from Tarifit to Dutch. And also what we see a lot is how certain words also exist differently in different languages, or certain objects have different names. And within the clinic for immigrants, every diagnostic material is adjusted to this group, which is very special and something that you really don't see a lot. And also they are using an interpreter. So this is like really hopeful to see, but it also at the same time makes you aware of how it's definitely not the case across other specialties, and how a lot of medical mistakes are being made due to the lack of language concordance. And that's something factual, and something that if ethnic is too political for you or too woke, then at least in language it's just true. It's just something that happens because you cannot express yourself to the doctor, and a lot of things go wrong in that process of having someone there translating for you, especially now that it's not covered by insurance anymore, and that interpreters are something that you have to provide yourself. People often take children with them, or a neighbor, or somebody else, if they're lucky enough to have someone who could interpret for them. I also worked at a general practitioner's office and as an assistant, and there was this man who didn't speak Dutch, but he had to make an appointment at the hospital. So I called the hospital for him to make the appointment. I didn't speak the same language as him. We used Google Translate. And then the nurse I was speaking to at the hospital said, well, he can't get an appointment here because he doesn't speak Dutch. If he has an interpreter, he can come. But if he doesn't, it's fine. Then he can't get any care from us. And I was so shocked by this. I actually had to get the doctor who was in the office to get them to at least give this patient an appointment. It was a man who had actually very severe issues that he really needed to be seen. And he was just like, no, as long as he doesn't bring his own interpreter, he can't get any care. And in the Netherlands, you have the tolktelefoon, which is the translator phone, I guess you could call it. So I was like, okay, then you guys should just call the tolktelefoon. I was like, well, that doesn't really work for us. And this was very confronting to me, because I was like, okay, so you're a healthcare provider, and I think if you are in healthcare, you actually want to help people. And in this specific case, you just don't want to help this man because he doesn't speak the same language as you do. And you also aren't willing to go the extra mile to ensure that this man gets proper care. But it really doesn't just stop at that. It's also about assumptions being made about certain patients, or not taking their entire context into consideration, such as their migration background, the way that led them here to the Netherlands. It has a very big history to it. And still people just look at their patients. In the lecture halls, we learn to recognize patterns, and you can't learn about every individual patient within a lecture hall. But when they are sitting across from you and you are their physician, you can learn about your individual patient. And it's so important that you try to do that. And unfortunately, we don't really see that happening a lot.
Oh, that sounds very frustrating. And especially since you highlighted what languages can do and what they contain. And I guess there's also probably a cultural component, right?
Yes.
If you know the language, you know the culture, you know the norms, you know how to address something, not just from a pure sort of semantic standpoint. So, and I realized while you're talking that I love speaking several languages through each other.
Through a bag.
I was just literally doing it as I was thinking it. Because there is certainly beautiful phrases in English, but then there's even better ones in Dutch for certain things. And with my friends where I can speak several languages at once, we often do that because it's beautiful to switch and have something that just places it perfectly.
Yeah.
So you reminded me of that. Thank you. So you put in the effort and you translate, which is very kind of you. What are the reactions maybe of the doctors you translate for? Like, do they then notice that it goes easier, smoother, that the care changes, improves? Like, what really is the benefit you notice?
I think that the clinic where I work is a very, very bad example of this, as all the physicians who see patients within this clinic are specially trained for this and are very motivated to learn more about their patients and the culture that they come from. We have certain doctors in the department who actually give trainings about this to other physicians and other caretakers in general about how to try to connect with a patient even when you don't have a lot in common at first sight. I think that for that reason, because they all have that, intrinsic motivation. I don't know if it's an English word as well. Mm-hmm. I also speak like 6 languages, so they always go it's a mess in my language center. But in this specific case, it's like those physicians, they are actually specialized in this. So they are physicians who are they don't actually understand the background, but they do know a lot about it, and they do try to understand as much as they can. For example, whenever they are speaking with a patient, they are not asking, with like a patient that's Muslim, they try to assess their memory by asking them questions about prayer. So, do you still pray? Do you still remember what to say during prayer? Do you remember where you were during prayer? So they really go the extra mile. And I think they are also very aware of certain other factors and the cultural context of the patient, and not just culture as in where they are from, but also the culture within where we live in, like in Rotterdam, but also the culture of having left your country and then going to another country that's like completely strange to you, and having to learn a new language and a new way of working, and your children growing up there. So there's a lot of that factors in. I don't necessarily see this as a caregiver or like a care enabler, I would say, because I'm not like the care provider, but I'm a translator, so I'm enabling that there's proper care being given to the patients. But I do see it as like a caregiver, as like the daughter of a patient. So for example, when I go with my grandmother to the doctor, and like recently I brought her somewhere, and usually my mother goes with her and she's a nurse. And I came in and the doctor was like, "Oh, who are you?" Because she usually she comes with her daughter. And I was like, "Well, I'm her granddaughter." And I don't want to say, "Well, I'm a medical student," because then it's like, okay, this medical student, she thinks she knows everything. But I do know my grandmother very well. So to her specific issues, I also really know what she needs or what she means by certain things that she says. And with this physician, I was very much clashing. And it was not something that I was used to, because I was working in the memory clinic and there were all these physicians who really tried to understand their patients. And then I came in contact with a doctor who just really stayed on the surface and treated my grandmother as every other patient, and also treated me as one of those people, as if I didn't know anything, while I sort of had a lot of expertise coming into that, not only to speak of my medical background, but also of the personal background of my grandmother. And I really didn't get the feeling that he appreciated that I could interpret and that I had that medical knowledge. It wasn't until I had to ask him like 5 times to give me the specific drug name of a certain medication that he wanted to try out with her, because she had already gotten that medication before. She didn't like it. So I wanted to know the name that he wanted to try. And he was just like, it's an anti-epileptic drug. And I was like, okay, but what is the specific name? Because she has tried several and there were some that she didn't like. Well, it's just an anti-epileptic drug. It might work for her pains that she has right now. And it wasn't until I asked 5 times and then was like, okay, but also I'm a medical student. I want to know the drug name. And I was like, oh my God, you're a medical student. That's so fun. What year are you in? And then sort of the conversation shifts, because there's an element of like being his peer in the sense of also being in the medical field. And that was really frustrating to me, because how, as just someone that's sitting here and translating for her grandmother, I was not worthy of the proper answer. But now that you know that I am a medical student, it's only now that you answer my question. I thought that was very weird. And I'm also, again, very aware of how that happens to a lot of people. And then I was also very concerned, because I don't have a medical degree, but I do have my bachelor's in medicine, and I know what to ask, and I have that expertise. But there are a lot of people who don't, and there are a lot of people who don't have interpreters that are their granddaughters who are also a medical student. They just have to take their neighbor, or they don't take anyone because they are ashamed of certain problems that they have to go to the doctor with. And I'm very worried for them, and they're having to encounter someone who isn't willing to go the extra mile to actually deliver proper care. I don't know if I answered the question.
No, I think that there was quite a lot of examples that really make the issue clear. And I think it is hard to be open and embrace uncertainty and share these things. And there's also, of course, a time pressure component, right? If you have 10, 15 minutes for consult, or you need to call a translator on the phone, it's all added steps you need to do. Maybe it's not even paid for. So I think the structural component certainly could use improvement, that insurance companies pay for it. There's more time when it's needed. But
it's a system issue. It's a systemic issue.
Yes, of course. But it's also an individual issue of trying to be open, right? I think what your clinic has really nicely shown is that I'm sure they also have a very tight schedule and certain things they need to meet, but they try to be open to provide better care. So I think even within systemic constraints, it is possible when you want to. Yeah. Did you want to say something about it as well?
So when it comes to the language issue, I know that there are still lots of people who don't use it because they say, for example, that it takes too much time. Mm-hmm. But there's a lot of evidence-based recommendations that you can find online for how to do this well. So such as, for example, making sure that before the conversation starts with the patient, that you already have the translator on the phone. So if you call them ahead of time, or you use the app to request a translator who speaks a specific language, then right away when the patient comes in, you can have a conversation and understand each other. And I understand it might take some time, because everything that is said needs to be translated. So you might think, this takes double the amount of time. But actually lots of people who use it see that in the end, you save time. Because if in the first conversation your patient understands you and you understand the patient, then you need a lot less follow-up. But if you keep talking to a patient in a language that they don't understand fully, and they also don't know what to say to you in Dutch because they don't speak the language fully, then what are you doing? Then the entire 15 minutes that you have with them is basically a waste of time.
Yes,
because you don't get the information you need. And also it has a lot of risks if you don't use a translator, because what if the patient doesn't understand the guidelines that you have given them or the explanation of how to use certain medication? Maybe you will see over medication or under medication. So I really would like to call upon every healthcare worker to just make sure that you use an official translator, not a child, not somebody who might not know the medical words in the language that they translate to. But to just do it the right way. In the Netherlands, people can go to Zo schakelt u een tolk in.nl. And it's just, I as a sociologist do not understand how you can, let's say as a physician, not get a translator and talk Dutch to somebody who doesn't speak Dutch. That makes absolutely no sense to me.
Yeah.
Because
especially since we know that medical language is already too much, right?
Yes,
most patients don't understand it. And we now have research and have understood that we need to explain things simply.
Mm-hmm. Yes.
And that also only 10% of what you say sticks. So we have learned a lot. So it really seems also obvious that you then need to do it in the patient's language.
Exactly. And even, for example, when I'm really sick and I go to my GP and the GP tells me information, if I'm super sick and I feel miserable, 2 days later, I will have forgotten what the doctor said if I didn't write it down. Just because sometimes your brain is not in a state of listening as you would, for example, when you're in a classroom having a university lecture. That's just how the brain works when you're really sick.
Yes.
So if it's already in a language that you don't understand in the first place,
It adds to the issue.
So
Or it becomes the issue.
exactly.
Really. Yeah.
And so when I was doing my research on working with the big register data, and I saw how few people there are with certain migration backgrounds, for example, with a Turkish or a Moroccan migration background, I realized hey, if you are a patient who speaks a language from this origin country and you are looking for a medical specialist in this field, then there's only 2 or 3 or 4 or 5 in the whole country. So what are the odds of finding them? Because there was no way to look for healthcare providers based on the language that they spoke. And that's why, together with 3 others, we started the website ikspreekmeerdan.nl, where people can look for a healthcare provider who, based on the language that they speak and based on the medical profession as well. And you can enter your postal code to see how many kilometers are you away from the medical professional's workplace. So I made this together with Ahmed Bayoumi, Daan Freije, and Emiel de Smit. And every healthcare professional we talk to about this website is so happy that it exists. And they're like, oh my God, finally. Because there was nothing like it while we are a country where a quarter of the population has a migration background. And of course, lots of those people will learn Dutch, or have learned Dutch. But as we discussed, with the work of Soumeya, if people get Alzheimer's, they will forget it. If they learn Dutch as a second or third or fourth language in their life, they will forget it when they really have Alzheimer's. So you need medical specialists who understand and speak the language that is the first language of these patients. And the fact that some professions, such as elderly care medicine or geriatrics, have less than 10 specialists with a Turkish or Moroccan background, while 5% of the population has a Turkish or Moroccan background, that just makes no sense to me. Mm-hmm. And to come back to the issue of, when I changed my study program and I went to Barbados, that's where I first learned about the impact of racism, discrimination, but also the history of slavery and colonialism on people's health nowadays. So all these issues, all these systemic issues about systems of oppression, they still affect people's health today. And then when I applied for the PhD vacancy, which I've done, I realized I thought that medical professionals here would know the importance of diversity for healthcare, because I learned about it on a small island in the Caribbean at a relatively small university. So I thought in the healthcare field, this is common knowledge, because we as sociologists and political scientists and so on, we're learning about it on this little island. And I have never done a medical degree. So I just thought this is common knowledge in medical fields. And then I came back here to do this PhD and I realized, how is the importance of diversity not an essential part of the medical curriculum? Why do I need to teach physicians about racism? Why do I need to tell medical specialists about the influence of discrimination on people's health? Or even the influence of poverty on health, unrelated to ethnicity. Mm-hmm. Even if you have a white Dutch patient living in poverty, why are there physicians who do not know the myriad of negative effects of poverty on health? And then not just from a theoretical point of view, but also from experience. It would be nice to have more physicians who from experience know what poverty does to your health, mental, physical, everything. And when I found out during the beginning of my PhD that a lot of this was new information, especially to white doctors, I was completely baffled. And I even had to explain to some people that race is a social construct. I literally had to tell physicians here in 2019, this was,
still happens.
that biologically speaking, there are no races within humankind. I was extremely shocked that this was not common knowledge when I had learned about it so many years before then already in Barbados. And if you literally are working with systems where you have to tick the race, quote unquote, of your patients, and it even uses the N-word in Dutch healthcare, in some hospital systems, there's literally the N-word to describe the race of a patient. I was the road that we still need to travel is very long.
Yeah, I think it's also a problem of it starts within the curriculum, and I think this is where the curriculum should be cured. Like on one side, it's that what Lianne very much so greatly can emphasize. When you are very aware of the problem and you have lived it, or at least you're aware of it, you think it's common sense. And then whenever you are within the medical field, you really start to notice that it's definitely not common sense and it's not common knowledge. It's really something a lot of physicians and people in the medical field are not aware of. And then you are starting to see the importance of education. And at least it shouldn't have to happen, but it is happening. It's a problem. It's a lot of people don't know about it, so they should be taught about it at least. And I'm not even going as far as saying that we should have education on inclusivity and inclusive care. Let's just start at the education that's already there. For example, what Lianne just said about you can take the literal N-word as your patient's ethnicity or race in this case. But also within education, you are taught that patients who are it's about Black patients, but then it's described as the N-word, and that's so problematic because it's normalizing something for these students who are already not in contact with anyone who looks like their future patient population whenever they are a physician. But it seeps into every aspect of medical education.
It's very invisible, right? It's also dermatology, I think, was mostly done on white skin or more or less light-skinned individuals. And now we, I think, are starting to realize, well, actually skin diseases can look different based on skin color, and that more sort of you really need to learn it on all the sort of shades that they are. So I think we are slowly getting there. But the problem is, of course, when you're in the system and you have no awareness, you don't really trip over it.
I have a story to tell about that, about how people just don't even realize how strange it is, right? So we live in a very multi-ethnic society. But then, like you said, the dermatology textbooks and so on, PowerPoints during lectures, they mainly focus on how different diseases look like on white skin. And I had a discussion about this with a student, and he was actually very enthusiastic. He's like, recently, I also learned about how some diseases look like on different color skins. And I said, oh, that's nice. Which course was it? And then he very enthusiastically started talking about how there's this new course related to diversity and inclusion, and it's an elective. And that's where he learned it. And he was very happy because he finally learned this, right? And he was a student of color as well. But the more he spoke, the more I felt uncomfortable. And at first, I couldn't really pinpoint to why am I feeling uncomfortable. And then I said to him, but the fact that this is an elective means that it is mandatory for you, if you want to become a physician in this country, it is mandatory that you know how everything looks like on my skin, but it is an option to learn how it looks like on your skin or on your parents. Why is this optional? Is your health less important than mine? And then he realized, oh, shoot, this is actually strange. Like the university got to the level of awareness where they thought, oh, we also need to make it more inclusive. But then they put it in an elective course. How does that make sense when you have a country that is so multi-ethnic and you are located in a city that is multi-ethnic? And the fact that even a student of color is already is so immersed in this system where it is so dominated by whiteness, that even as a student of color, you don't even realize, like, hey, this is so unfair that now it's being put into an elective. Why not mandatory? Because all these people who are not interested in diversity and inclusion are not going to take this elective. And they can still become doctors while not knowing even how some diseases that might kill a patient, how they look like on a patient of color.
Or to add to that, like in this case, it was an elective, but I also think it even like where I did my bachelor's, it's a subject that everyone has to take. It's mandatory. It's not regarding dermatology, but it's like, I think a bit in general during the first year. And I was wondering, why is this a separate subject? Why isn't it something that we try to include in every aspect of the curriculum? And
Exactly.
I get that there's so much that we have to learn and we can't just learn about everything. But I do think that some issues should at least be mentioned to make people aware of it. Because if you've heard it 10 times in a year instead of just during one subject, it sticks. And it's something that you eventually become aware of, instead of only having one subject during the first year, or only knowing that there's an elective about it, but you never even saw any of the lectures.
Yeah. And that argument of like, oh, the curriculum is already so full, they already have to learn so much. That to me never makes any sense, because if I then pose to people who say that, if I say, okay, then let's do it in the coming 5 years, we focus everything on Black people and Black skin and Black health issues, right? So it won't add anymore, it's just different. So in everything that is now white, we make it Black. And then people are so confused, like as if that is totally unimaginable.
Yeah.
But imagine you're a Black student and everything you learn is white and it's focused on whiteness. So it's like, so if it is okay to have it dominated by whiteness, why can't it be dominated by Blackness for 1 year? If that is impossible to conceive, then you should realize that the current situation is ridiculous as well.
It's very, very clear, and I agree that one single lecture will not fix this, or one elective. That ticks the box of, yes, we have something to offer students, but
exactly.
It doesn't challenge the underlying issues and biases and so on we all carry. So we already talked a lot about like direct recommendations regarding translation to improve sort of the language barrier and finding a physician, but it goes deeper than language, right? You want someone who also understands the culture and other aspects of health. I was really wondering about the structural things, because we touched upon the leaky pipeline in the beginning, and you said we select doctors based on certain criteria, and that's not good.
Yeah.
So then do we then just do a lottery, or where along the leaky pipeline do we need to focus?
So there are several points that are really important in terms of the leaky pipeline. First is the step from primary school to pre-university education, so in Dutch called VWO. And there we already see the major loss of diversity in terms of ethnic background and socioeconomic background. And nowhere in the rest of the pipeline to medical specialists do we fix that issue. So it only gets repeated. But because of this leak in the first step, the pre-university education student population is already disproportionately consistent of people without a migration background and with wealthier parents. So lower socioeconomic status, very much filtered out already. Average socioeconomic status, underrepresented as well. So that means that once people apply from that pool, once people apply for a study such as medicine, you need to compensate for the inequality of opportunity in the first 18 years of these kids' lives, because it's not their fault that, for example, if you have a migration background that is underrepresented or a socioeconomic background that is underrepresented, it's not your fault that the groups to which you belong have had lower opportunities in the first 18 years of life. So you need to compensate for that in the selection procedure, because there have been systemic barriers preventing a lot of your peers from also getting there. And if you don't fix that at the moment of admission to medical school, you will always have a medical student population and therefore also a physician population that doesn't represent society. Because only when you admit a student population that represents the diversity of their peers, like their age group, regardless of the level of secondary school education that they had, in terms of migration background, socioeconomic status, etc., they should reflect their peers. Because otherwise, once they are physicians, they will not look like the society that they serve, because their peers who did not go to medical school will also become their patients. And also we need to look at this when it comes to the selection of residents. So once people are physicians and they want to become a medical specialist, they need to enter residency training. And here again, we fall into the same traps as the selection for medical school, because we look at individuals and their achievements, irrespective of the context in which they were achieved. So in both cases, for example, we look at grades or CV and things like that without taking into consideration that some people have had so much help along the way to get high grades, have had so much help to get into the right jobs or extracurricular activities that would look nice on their CVs. And we forget that we have a country with a lot of labor market discrimination. So people who don't have an amazing CV might have applied as well and might have been qualified, but may just not have gotten the job because of their surname, right? Or their socioeconomic background.
Or even more, they just don't know
Exactly.
That's also a problem. A lot of students don't know what they have to do to be desirable within the selection, to be selected.
Exactly.
And that's also where the issue of having a parent who has already been through that system, it helps you. And I noticed it a lot because when I applied, I also had to have help from certain colleagues that I met in different jobs who were already medical students. But I also noticed with cousins. I have one cousin who just got admitted to medicine and she really didn't know anything. And I had to explain everything. And then she was lucky enough to have a cousin that had already had her bachelor's. But I know that there are a lot of students who are not that lucky by far.
Exactly. And as long as the whole society is full of social inequalities and systemic barriers to getting ahead for some groups, we just cannot organize a selection procedure, whether it is for medical school or for residency selection. We cannot organize such a procedure as if all those inequalities don't exist, as if everyone has had exactly the same easy route to get there. No, you need to take into account that some people just have, very slippery mud thrown on their path, right? When they try to walk this route, whereas others have been helped all along. And when I give presentations, I always make this comparison between two people who are cycling the route to university. And one has an electric bike and has many spots along the route where she can recharge the bike and keep going really fast. Whereas another person might have a normal old bike without electronic or electric support.
A bike that got stolen along the way as well.
Exactly. Yeah. So, and then a third person might not even have a bike at all and has to do this whole route running barefoot. But that doesn't mean that the person who gets there first on the electric bike is the fittest person of the three of them and is the most suitable candidate to admit. Because what does this person know about, having the wind in your face? If you have an electric bike, you don't even feel it. You always have the wind in your back if you have an electric bike. But the persons who had to do it without electric support, they know what it is to really get ahead by using your own strength, your own determination, your own power, also when the wind is blowing in your face. And a lot of selection committee members, also for residency selection, don't look at it like this at all. And then when it comes to the residency selection, we know that in a lot of fields, people value a PhD. And I've done a PhD and I applied for it because the job was on academictransfer.com. But I know that in the medical field, some PhD vacancies are never advertised. Everything is done within the social network of the professor who has to hire somebody. So if they just let a few or a limited number of people know that there's going to be a vacancy for a PhD, then what if you're not in their social network? Mm-hmm. So if you've never had the chance to apply for a PhD because it was not online on a vacancy website, then how can you be punished for not having a PhD behind your name? That makes no sense. If the access is not there equally for everyone, you cannot judge people on not having achieved that milestone. And to me, it's just baffling that things go like this, because next to the injustice in itself, the whole residency training in the Netherlands is paid for by the taxpayer. So that means the entire patient population, right? Because we are all taxpayers in the end. And I feel like as a country, we should be able to expect something of how this process works, because it's done with our tax money. And in a lot of cases, it's not done in an evidence-based manner. It's not based on what science says
should happen.
Or
is the best for the patient population.
And a lot of times we see that the selection procedure focuses on who do we want as our colleague. So it's the medical specialist selecting who they want as their colleague, but the patient's perspective, who is the most suitable candidate for our patient population, is very often not taken into account. And then I'm just baffled. Like, why is it organized this way? Why is it done with such little regard for what the most disadvantaged patient populations in your area need? And to me, something like multilingualism is such a no-brainer to use as something to reward. If you have a candidate that speaks 6 languages like Soumeya, how can that not be valued in a selection procedure? Whereas somebody who did, I don't know, the beer committee in one of these student fraternities, right, Minerva or Vindicat or whichever one, why is that seen as something good? That you were in some student association's committee arranging the beer at your building of your fraternity? Like, what is the relevance to the patient compared to a candidate who speaks 6 languages? It's just shocking to me how this still has not changed.
Probably shows that you're able to jump through hurdles that are set.
Yes, yeah. And some people just don't have any hurdles. And then they are there at the end of the pipeline as a medical specialist on top of the monkey rock, as we say, right? The biggest monkey on the rock. And then they want to talk to me about something like own responsibility, right? As if they got there purely based on their own merit and they haven't had help along the way. As if it is their achievement or their own merit that they had, for example, their own room as a child to make homework, that it is their responsibility and their effort that their parents had a lot of money and that the fridge was never empty. None of that is your own achievement. Yeah. And I really think that every medical student should have sociology courses to learn about these things, because like students who come from marginalized backgrounds or backgrounds that are in a minority, when I speak to them, they know this. Most medical students with a migration background and who are of color or who come from a low socioeconomic background, they already have a sociological understanding of these things because they have lived the inequality, because they have experienced racism or discrimination. The students of Soumeya's age are from after 9/11. They don't know another Netherlands than the Netherlands in which they are seen as second-class citizens. I don't need to teach them about sociology of like social inequality or sociology about systemic barriers to getting a good health. But it is the people who are in the majority group in medicine who very often have no idea what life is like outside of their bubble.
So I would go a step further than just a course. I would say you should go abroad. You need to experience it, because I think, for me at least, then it became clear when I went abroad and I experienced it for the first time, that it really is a problem and it's not just on paper.
Yeah, but even if you don't, for example, have the opportunities or the money to go abroad, if you, for example, in Rotterdam, there are so many people living in poverty. There's so many homeless people. So maybe work a while with what we call street doctors, right? Go to doctors of the world and see how it is to provide healthcare to people who are homeless or who live in extreme poverty.
Or just go to Black on Saturdays, where they are. They have during winter they always have a food drive on Saturdays at Black for the homeless community, and talk with someone instead of running away from them or being scared by them, and you will see how the system has filled them. And you will start to notice all these cracks where a lot of things are going wrong within the medical system at every single step of the way. And it always starts way earlier, also in education. When engaging in certain youth programs, you often talk to little children who would say, well, miss, I also want to study medicine like you someday, but my teacher told me I could never do that. Then maybe I should consider nursing or social work. And it, like for me personally, I have been told that a lot of times. There were a lot of teachers who were like, well, you talk a lot, so maybe you should just go into social work or something, which at one point, the funny thing is I also considered, my father was a social worker for many, many years, and I know that it's very noble work, but it's not something that I am doing or I am pursuing right now. And why would it be unreachable for me to become a doctor? And that's something that we try to tell those children, but it's really hard to undo that systemic failure of being told that you couldn't do something over and over again just because of where you're from or how much money your parents do or don't earn. There are a lot of things where we should really improve.
Yeah, I think there's a lot in everything you have shared and what an individual can do in terms of just in one patient conversation, but there's also a lot of work that needs to be done at a systematic level, not only in universities, but before universities, within society. And I think it's crystal clear that this work needs to be done should we want a just healthcare, or at least a healthcare population that represents the average population for adequate care, right? So
not just adequate, it will be, we know that from research that you need a representative healthcare population in order to be able to achieve excellent care.
Okay.
Right? So it's not just about adequate care, but when you become a lot more representative and inclusive as a healthcare workforce, you will be able theoretically to achieve excellent healthcare. Because right now, yes, we do have a system where we are able to provide excellent healthcare, but it helps certain populations and not all. So if you speak to a patient in a language they don't understand, that is not adequate health, or that is not excellent healthcare. No matter having the latest MRI scanner in your building or having the most advanced technology in order to maybe use it for diagnosis, if the patient does not understand what you're saying, then that is not excellent healthcare. So you need to be able to make the translation of the excellent healthcare that we provide to those who already have access and who understand everything and who have the money to follow up on all the recommendations, to make the translation of that care to also the people who now have the lowest health the lowest life expectancies, the worst health outcomes. Like, we need to make sure it works for everyone.
Yeah, very, very clear. So maybe to round off, what's one thing you would like to ask current students to do, future healthcare professionals, maybe faculty who are listening? Is there a recommendation you have? Is there something you would like to see? There's a lot.
There's a lot.
Yeah.
Having to choose one, I think something that I also really try to tell people whenever I talk about lived experiences as a patient, but also as a provider. I think it's very, very important, and it applies in the entire context of healthcare professions, but specifically when dealing with patients from marginalized groups, is try to understand your patient. And it's something that every patient will tell you whenever you ask them what's your tip or your advice for healthcare workers or future physicians or nurses or anyone who might provide care in any form or way. It's always try to understand your patient, but I really think we should try to understand our patients and not just where it hurts or what medication they've already tried, but also where they are from. And then in their entire context, the cultural context, the language they speak, but also who they are as a person. It influences the way they experience disease and the way they experience health, and also try to find what you have in common with your patient. And it will really improve the way you can provide care.
And we can extend it to faculty, get to know your applicants.
Get to know your applicants.
And the road they have traveled, with an e-bike or not.
Definitely, but also try to teach, it's different advice for faculties. Try to teach the importance of understanding the entire context of your patient. As long as it's only an elective or just one course in the first year of medical school, we are not actually fixing the problem. It's something that should be included in every day of medical education. Only then can we provide adequate care. We are speaking of excellent care, but we haven't even reached adequate care for everyone. So the system isn't just yet, and it's something that we should really aspire to achieve.
Thank you.
So in terms of my research, a lot of recommendations that I would have can be found in my PhD thesis or in my postdoc reports. But I think there's one major recommendation that didn't really fit into the academic publications, but that I think is the major one for students personally, but also selection committees and maybe also, basically every healthcare worker. If the circle of people you love is very homogenous, if people all look like you, then you might not be able to really, if a patient doesn't look like you might not be able to see them as like, hey, this could have been my mother-in-law or my brother-in-law or my best friend. Then you might miss that insight in their world, in their social world, in their life. Whereas if your circle of friends or people that you love is much more diverse, then you can basically recognize your friends or your partners or your family-in-law in anyone. Mm-hmm. And that's what I miss when I have conversations with people who live in a very small bubble, is most of the world is the other to them. So any person of color is the other. Any person who is Muslim is the other. Any person who doesn't speak Dutch the way they do with their accent and their specific words is the other, right? But if your circle is extremely diverse and reflects the world that we live in, then you see your friends in your patients, your family-in-law, the people that you care about. And I think if you have that, then it's so much easier to make a connection with the patients that on the first glance might not look like you. And to me, that was really helpful. Like when I went to study in Wageningen University, that's when I, for the first time in my life, basically got a really big group of friends with people from all over, with different ethnic backgrounds, with different religious backgrounds, because I come from a very white village. And that, I think, has been the most impactful thing since I started studying in 2008, just being friends with people from all walks of life. And that makes it so much easier to connect to new people who might on the first glance look different from you, but in the end are not.
But it's also so enriching for your own personal life.
Yeah, definitely. And it just makes it so much easier to go through life in this world that we live in, because people who on the first glance look different from you are such an important source of like new stories, of experiences, of insights, of knowledge. And if you close yourself off from all that, then I just think that life is a lot less colorless.
Yeah, and you're really robbing yourself from all that richness.
Yeah, definitely.
Yeah.
It's such a wealth of fun and wisdom and understanding that you lack if you stick to only what you know.
It's out there, and you just got to open up. But it's a hard road, and it's especially hard when you don't see the option. So I think it's become pretty clear that we should try and see it and try to engage with it. Thank you both very much for your time and all your stories.
Thank you.
It's been very valuable, and we hope that that over time the leaky pipeline will become less leaky, and that the healthcare population at some point will represent the average or the general population. So thank you.
I hope so too. Thank you.